AKI, acute kidney injury. The NHS should be on the lookout for it, according to NICE, the National Institute for Health and Care Excellence. It says that between 12 and 42,000 lives a year could be saved by simple checks on the kidney function of hospital patients.
So the programme has an ambitious plan to improve outcomes for patients. And that essentially is we want to reduce avoidable harm to minimal levels. We want to reduce mortality associated with acute kidney injury, and we want to improve the recovery of people when they have an episode of acute kidney injury.
The AKI national programme hopefully will enable the early detection of acute kidney injury and ensure the right interventions are put in place at as an early stage as possible, because by the time the disease advances, it's too late.
From the patient's perspective, this programme of work will provide a real opportunity to ensure that they aren't occurring any incidents. We want to eradicate avoidable AKI wherever possible.
I envisage an NHS where acute kidney injury and patient safety are at the heart of everything that we do. It'd be nice to think that it's just in the water, you don't notice it, but everybody has it embedded and is thinking about it. That's the only way we'll really prevent these terrible effects it has on patients.
I envisage an NHS where acute kidney injury is in the consciousness of the public, patients and professionals.
Although there's a huge new focus on acute kidney injury across the world, no one else has attempted to do a national programme at scale and pace addressing risk and education and intervention and all the other work streams, and trying to have a national programme that will improve outcomes of people at risk of and with acute kidney injury. The ambition to have a national register of people with kidney disease and be able to track outcomes and set up this programme as a self-sustaining programme is really big. Why would not want to be part of that? We've delivered what I think is a pretty robust package of documents and advice and guidance documents, both for primary and secondary care. I think the secondary care stuff has been really important, particularly audit measures, but the secondary care stuff was largely drawn on existing bundles and other interventions that have been designed in secondary care. The primary care stuff is groundbreaking because nobody before had really worked out how primary care should address acute kidney injury.
For me, a key success of the programme has been about the engagement with lots of different types of health professionals, and particularly generating dialogue across the interface between primary and secondary care. I think that provides a platform for enduring partnerships locally, regionally, nationally as we go forward. I think a key challenge that we've held in mind in our primary care working group is about how to maximise the clinical utility of being aware of the risk of acute kidney injury in the assessment and management of people, whilst also minimising the potential for workload burden for clinicians and also treatment burden for patients. I think to date the Think Kidney's primary care resources that are on the website have been accessed over 12,000 times since April 2016, and I think that's a recognition that AKI is of relevance in the management of people in primary care and across the interface. I think that the resources themselves are a starting point, and I think the next step is how do we build up an evidence base about how to put them into practice, and then further down the line, how do we build an evidence base around their clinical effectiveness and their cost effectiveness.
I think prior to the work stream, basically there was no single resource or place that a person could go to, a healthcare worker could go to find the answers to these questions. So I think there was a huge need for this medicines optimisation kit, because in one place, in one document, you've got the nasty medicines to look out for, the ones you need to stop, the ones you need to monitor, the ones you need to change the doses of. It's all there in one resource, and I think there was a huge need for this document, and hopefully we've addressed that need.
So I think there's been very strong work driven by Catherine Griffiths in primary care, which is the whole GP educational framework, the GP resources that have gone out with the scaling of electronic alerting into primary care, And I guess the workstream's also been working with BKP on the patient information leaflet, which I think has been quite widely used. I guess we're trying to do three things. We're trying to get some educational messages to the public at large, particularly, kidneys are important, what they do. There was targeting particularly at-risk patients with chronic kidney disease, and also there was our engagement and educational initiative pointing at healthcare professionals at large.
I think it's fair to say that when you're looking at education, there are so many different institutions and so many different people who come at things in different ways. Trying to get some consistency of message has always been difficult, but I think we've achieved that. But also getting people to engage adequately, developing undergraduate curricula for the various professions is always going to be a very, very difficult task. Postgraduate, undergraduate, we really haven't made much inroad to, and I think that is something that we do need to look at in far more detail to ensure that the doctors of the future, the nurses of the future are adequately educated about the impact and the effect of AKI.
Well, the drivers for me getting involved in the Think Kidneys programme was really about having that representation from primary care, and the fact that acute kidney injury was something that came from primary care into secondary care and back out into primary care, so it needed a GP voice involved. How about you, Andy?
I think it was the possibility of bringing together such a disparate group from across many different specialties and involving so many other individuals such as patients to have a coordinated approach to this very heterogeneous condition, and that really excited me. And the fact that it was divided into very specific work streams, it struck me as a very well organised way to approach a very tough disease condition. And we can see a legacy there, I think, with the work as we go forward. This is a resource that is not just recognised within the UK nationally, but also globally. People quote the Think Kidneys programme and the different work streams.
I think one of the big challenges going forward from where we are at the programme at the moment is to actually carry on what we started, which is this pilot project on how acceptable leaflets and cards are to patients who are considered to be at risk, and actually analysing that properly so that it can become a resource that's used nationally if it's found to be appropriate, and also not losing the momentum that we've had, because I think the momentum that's been over this last couple of years with the release of acute kidney alerts out to general practice and all the resources, what we need to maintain is that interest in acute kidney injury ongoing, that it isn't just something that comes up for a couple of years and then people sort of lose enthusiasm for investigating and responding to their patients early.
The driving motivation behind improving AKI recognition is that this should translate into improvements in patient care. We've considered this as part of the detection work stream by making sure that the detection algorithm is joined up to other work streams, and that the detection and alerting of AKI isn't seen in itself as a solution, rather it's seen as a tool to help doctors recognise acute kidney injury in a more timely fashion, but then act more quickly and deliver patient management in a more timely way. We're beginning to see positive results of this joined up approach from different centres around the UK, and at the moment there are a number of multi-centre trials that are evaluating this concept more rigorously, and we very much hope that our work that we've done in this area will translate into direct improvements in patient care.
A long journey from the start of the initial discussions about how we would detect acute kidney injury with the resources we had in the laboratory, all the way through to having a national group formed where we had significant input into how this would work for all laboratories, and again adding on to that the training, the alerts, as well as all the interactions and guidelines that are being produced. So it's come a long way from the initial how can we do this to getting it set up in Derby, to getting it set up in other hospitals nearby, and now nationally being rolled out.
The measurement work stream brought together people who'd had acute kidney injury, people who are at risk of acute kidney injury, and doctors and laboratory scientists from across the pathway of care for people with AKI. And I think we worked as a group by sharing each other's perspectives, and I certainly found that I learned a lot by understanding the problem of how to detect AKI, measure it and capture it in the data that the NHS collects by looking at the problem from multiple perspectives.
We had patients representative on measurement workstream, and they contributed immensely to what data we are collecting and what they want to see from this data. So for example, our patients want to know what is the incidence of acute kidney injury in their region. They also want to know what happens after an episode of acute kidney injury. So in terms of morbidity, they want to know what is the mortality, what proportion of patients go on to develop chronic kidney disease, and how many of them recover their renal function back to normal.
I've contributed to the AKI programme by being on the measurement work stream, and it was very important for patients to be involved. Patients' data is very sensitive, can be very sensitive, so it's very important that patients take part and understand the processes.
People who use the NHS need to know what the NHS does for them. And for people who have acute kidney injury, we haven't really had a very strong grip on what the NHS achieves. And that limits our ability to understand how we can improve care. So I think it's really important that we measure outcomes in acute kidney injury. Firstly, so we know what's the scale of the problem, and where is it occurring? Is it occurring mainly in the community? Is it mainly occurring in hospital? And what happens next to people who have acute kidney injury?
So we've been able to create opportunities at a national level through, for example, through the patient safety alerts and the national sequin to create the momentum, and that momentum is around then being able to produce sustainable change at a local level. We've absolutely achieved in this programme what we set out to, just going back to what I was saying earlier about our ability to provide so many resources, so many sort of blocks, or so many of the building blocks to support the system, I think has really been one of our big objectives, and looking at the measurement as well, being able to provide the measurement tools and the data to support and to be able to assess that change. We've absolutely really achieved what we wanted to do, and it's been great.
So I think we've done a lot more beyond the initial scope of the programme. We've achieved a lot more. And that came about because we didn't have a fixed plan for the programme right at the outset. We allowed the programme to grow organically. That allowed people to come up with ideas and for us to talk through and to fit them into the programme. So let's give some examples of that. I think two things stick in my mind. The first is the public campaign. So I didn't have it on my list of things that we had to do or should indeed do. I felt it was beyond the scope of this programme. But actually we ran a very focused, very tight, very successful public awareness campaign around kidney health. And that came out of another thing that we just didn't think about, which was to interrogate people's awareness of kidney health. So the fact that only half of people really know what their kidneys do was a surprise to me as a kidney specialist. But we should have thought about that, and we needed to address that issue as a fundamental. So that was a major success. The second thing that really stands out for me is the work that was done in the care homes. And it's not just about the detail of the work, but how that came about, how people within that care home sector embraced the ideas around it and understood how they would make it work for them. And again, as a specialist in the hospital, that's a perspective that I wouldn't have known about unless we went and asked them about that. And that's why it's very important not to have these fixed ideas of these are the things we're going to deliver and those are the only things we're going to deliver. Out of it came the fact that acute kidney injury is now very well embedded into the mindset of a vast array of professionals, many of whom we couldn't have thought about at the start, and people talk about acute kidney injury with a degree of certainty that we didn't see before.
My big fear for the future of the programme is the way that it's embedded and spread within the NHS. We have limited funding that will allow us to maintain the set of excellent resources that have been developed by a lot of people who've worked very hard on this and given their free time, done a lot of very good work. However, unless that's taken into the NHS, spread and really embedded, we will still be running a programme as we have done so many times in the NHS. And one of my big frustrations is we run programmes and don't make sure it comes into the routine work. I think when I first started, I said I'd like to see this in the water. Now, and we can only get to that stage if people take on the work of things like tackling AKI and the excellent work Nick Selby's doing there. If the patient safety collaboratives really drive some of the work that have been developed through Think Kidneys. So there are some real challenges to others there, whilst we'll maintain our resources, how they take it and embed it, and how clinical teams take this and embed it in their normal routine practice will be the real challenge going through the next period of time.